I want to take the next few minutes just to talk briefly a little bit about addiction and crack cocaine. We're going to go over what crack cocaine is, some of the effects it has on users, and how that relates to addictive patterns. So we'll begin by just describing what crack cocaine is. Crack cocaine begins as cocaine powder that is then combined with common household products and heated and cooked. And through that process, it forms crystalline chunks. These are solid chunks. And because of the sound that it makes as that process is happening of cooking the powder, mixing them with these household products, it often cracks apart and makes this noise. So it's part of the reason why it gets the name that it does. So cocaine powder mixed with common household products, cooked together to create solid chunks, crystalline form. And then this result, this solid chunk, is placed in a pipe and ignited, and the vapors are inhaled directly into the lungs. It is essentially smoked. The inhaled vapors produce an almost immediate whole body euphoria. You just feel from head to toe, it has been described as a whole body orgasm. So almost immediate high, whole body euphoria. It creates increased energy. It has a profound effect upon the body. The problem comes that when that high then comes to an end, when the chemical then is processed and removed from the body, what has typically been called the crash follows. And at this point, the person goes from whole body euphoria to deep feelings of depression, anxiety, paranoia, and fatigue. And of course, a strong desire then is built up to reacquire that sense of whole body euphoria and reacquire the drug in order to produce that feeling and to get rid of the feelings of anxiety, paranoia, and fatigue. So this pattern obviously builds on itself, which is why we talk about addiction here, that the addiction builds not only physically and chemically, that the body needs the material, but the person psychologically wants that feeling of whole body euphoria and wants to get rid of the feelings of anxiety, paranoia, and fatigue and depression. So there is this psychological as well as physiological need created for the substance. Therefore, it is highly addictive. When we talk about levels of use and how much is ingested, it creates different effects. So low levels of crack produced an increased heart rate, increased temperature, and increased energy, and decreased appetite. So not as hungry, increased heart rate, temperature, and energy. It also produces, along with this, constipation, insomnia, impotence, and weight loss. Because of this right here, just at the lowest levels, because of the elevated heart rate and temperature, elevated energy, decreased appetite, and depletion of the body of fluids, once again due to the increased temperature and other things like this, it produces the side effects of constipation, insomnia, impotence, and weight loss. Now, as the amount goes up that is consumed, it starts producing other effects, which of course are much more negative to the body. Things like convulsions, nausea, twitching, seizures, stroke, respiratory and heart failure, and ultimately death can ensue as the quantity ingested goes up. So crack cocaine, once again, a product of cocaine powder mixed with common household products to produce this hard rock-like substance that is then ignited, the vapors inhaled. The reason it's done is because of the almost instantaneous whole body euphoria, and the addiction comes in not only because of the substance itself is highly addictive physiologically, but psychologically. When the person comes off the high, they are almost immediately assaulted by feelings of depression, anxiety, paranoia, and fatigue, and in order to get rid of those feelings, they seek once again to find this substance to replace those negative feelings with the positive euphoria that they had before. It's a very dangerous substance, not only because of the short-term effects with the elevated heart rate, temperature, and energy, decreased appetite, producing some of these minor situations of constipation, insomnia, impotence, and weight loss, but the long-term effects as people increase the dosage and increase the amount that they're taking, leading to these horrible consequences of convulsions, nausea, twitching, seizures, stroke, and then finally breathing and heart failure, and ultimately death. It is a highly addictive substance, both physiologically and psychologically, and help is definitely needed if someone is using crack cocaine. If you'd like to learn more about this and things related to it, beneath this video there's a link. If you'll click on it, it'll take you to the website with that information, and while you're there, you'll also find a link to an ebook that's ready for immediate download. Nick, please disregard the video right before this one. I skipped down to number 2 and was describing depression instead of disorientation. So sorry about that. This is the video, assuming I get it right on this take, that you want to upload. I'll pause for a minute and begin again so you can get the editing. Thanks, buddy. For the next couple minutes, I'd like to go over some of the common behaviors, characteristics, traits involved with people who've had brain damage. So those who have had brain damage in one form or another will exhibit some or perhaps more of the following characteristics or behaviors. So number 1 we want to talk about is disorientation. Those who have had brain damage sometimes feel disoriented or confused. They are bewildered and suffer perhaps loss of direction. Where am I going? Loss of position. Where am I right now? Loss of time. It's already the afternoon. I thought it was still morning. And this results from often an altered attention span and from an altered memory because of the brain damage. So disorientation would be one of the behaviors or characteristics common to someone who's had brain damage. 2, we want to talk about depression. Here, this is a state of unhappiness or hopelessness manifesting as withdrawal, crying, apprehension, or petulance. It's a depression not associated with something going on in their life, but is a direct result of the brain damage. Next, we want to talk about impaired judgment. With brain damage, we often find people unable to assess the consequences of actions and respond appropriately. Their judgment has been impaired. For the person who has not had brain damage, usually, if they've grown up normally, they are able to assess the consequences of actions and therefore make the appropriate response. But those that have had brain damage are incapable sometimes of doing this, and so their judgment is highly impaired. Along with that, similar to but different, is impaired problem solving. Impaired problem solving, the inability to describe or analyze a problem. What's wrong? I don't know. Well, can you tell me that something is wrong? Yes. Well, tell me what is wrong. I don't know. Well, or maybe they know. Well, how are we going to solve that? I don't know how to solve it. It's overwhelming. So they are not able to describe or analyze a problem. They cannot come up with a strategy to deal with the problem. They can't even analyze the results. Did that go well? I don't know. What do you think? Did it go well? So the impaired judgment means they can't assess the consequences of actions and then respond appropriately. Impaired problem solving means they don't know what the problem is, or if they do, they don't know how to solve the problem. They're not even sure if the problem was solved. Next, we'll talk about impulsivity. Impulsivity, this is an inclination to act or respond to sudden urges and desires without considering the consequences. I'm going to go buy a new car. Well, do you have the money to buy a new car? I don't care. I'm getting a new car. I want it. I'm going to go do it. So they've got this impulsive desire and they immediately follow through on it without thinking, what are the consequences of this? What will this cause or do? And so impulsivity can also be a behavior associated with brain damage. Next, disinhibition. Here, basically, the ordinary societal and internal inhibitions that people have are completely removed. Where most of us would stop and think, I don't want to embarrass myself, this isn't appropriate for this context, this isn't right for our culture, our time, our society, or whatever. Disinhibition, due to the brain damage, leads someone to just, I want to do this. So they might walk into a room full of people and disrobe. Ordinarily, we would all be inhibited against public nudity like that, but this person, due to the brain damage, sees no problem with that and has no inhibition whatsoever to doing things that would not be considered appropriate otherwise. Next, over here, number 7, we're going to talk about agitation. Those who've had brain damage are often in an agitated state, nervous anxiety, irritability, lack of attention span. Sometimes they're highly unrestrained in their behavior. There's a great deal of perhaps aggression, maybe anger, so they're agitated, once again due to the brain damage. Next, apathy. Those who've had brain damage sometimes can exhibit patterns of behavior of being completely apathetic, disinterest, lack of motivation, lack of energy, complete emotional emptiness. Next, lack of initiative. And here with initiative, we don't just merely mean getting the ball rolling, getting something started. Not only do they fail to initiate, but they don't follow through and complete either. So you try to get them started on something, they don't start, or if they do, they give up quickly and don't actually complete what they're supposed to be doing. Lack of initiative. They also sometimes suffer from lack of insight. Lack of insight. They are not self-aware. They are incapable to see situations clearly, or they often live in denial. This is what's going to happen if you do that. No, it won't. It will. And so they basically live in denial. They don't see situations clearly. They're not self-aware of what's going on. So they lack insight. They also sometimes exhibit emotional lability. Here, there is extreme or excessive emotion that swings wildly from side to side without any apparent external stimuli to produce that. So they would go from absolute crying to laughing hysterically with nothing in between to, one, explain the laughter or to explain the crying. They just back and forth, excessive emotion and a quick change in mood, vast mood swings, emotional lability. They also exhibit perseveration. Perseveration is repetition, repetition, repetition. They say the same word, perform the same action, get stuck on a particular topic over and over and over and over again, long past what would be considered normal or appropriate for the situation. They show an inability to move on to other things, a complete fixation on something. So the repetition of words or phrases, fixation on a particular topic, or a repetitive behavior done incessantly. So perseveration is a type of behavior commonly associated with brain damage. And then finally, confabulation. Patients with brain damage and also dementia exhibit this particular behavior or trait. Confabulation is fictitious creation of details about past events. This is ordinarily done to compensate for memory loss or to alleviate anxiety. So I'm fearful or I've forgotten, so instead of saying I'm afraid or I've forgotten, I'm going to make something up. Confabulation. Fictitious creation of details about past events to try to cover over the fact that either they don't remember or they're afraid. Once again, seen not only in those with brain damage, but dementia as well. Anyway, that's a lot of different things to go over. We've looked at 13 common behaviors associated with brain damage, and if you'd like to learn more about this, there's a link underneath this video, and I would encourage you to click on it, go to that website. There you'll find more information, and there'll be a link at that website that will allow you to download an ebook. Today I want to go over just briefly borderline personality disorder. Borderline personality disorder, BPD, also known as emotionally unstable personality disorder. There's some perhaps changes in the works to change the name from borderline personality disorder, as some people feel that it stigmatizes the person suffering from this difficulty. And so one of the suggested possibilities is emotionally unstable personality disorder. Basically, you have someone with BPD who is suffering from an unstable and highly chaotic personality, especially in their mood swings. And usually those mood swings are not associated with circumstances in their life. They're not consistent with the things around them. So they can swing from everything is great to everything is dismal. The world is perfect, and now the world is going quickly to destruction. People are either all good or all bad. You are perfect, you are evil. I love you, I hate you. And it's this back and forth pendulum swing that makes it very difficult for those around the person with BPD to relate to them, because there's no way to predict what person you're going to receive. Today you may be the good person who's perfect and great. Tomorrow you may be the most evil person on the planet and they hate you, and there's been no context, no change to make that reasonable or understandable. So basically you've got an unstable, highly chaotic mood swings. You have extreme anger, often is the indicative here, extreme anger with no context to justify the anger. The person is just ballistic with anger, and you're trying to figure out why, what happened. Know of a particular case where a family member perhaps had something along these lines, but essentially what would happen is whoever showed up last was the good person. So someone shows up to visit, they're the first person there. Well, they're good until the second person shows up, and now a switch takes place. The first person who arrived is now the bad person, and the new person who arrived is now the good person. And so this person with the difficulty would say, oh good, you're here to help me, they're trying to kill me. And then a third person would come. Now those two are in a conspiracy to kill them, and that person is now the good person. And there's no rhyme or reason to it in many ways. It's just this quick transference, this black and white thinking about people without real proper context to it. So extreme outbursts of anger with no proper context, extremely unpredictable, and often this idea of splitting is there, this all or nothing thinking, black and white thinking, mostly as it relates to people, how they are perceived and judged. So one minute the person that's trying to help them is there to save them, and they'll say things like, I love you, and you're here to rescue me, and I just can't live without you. But then suddenly, because they can't draw a clear line between their identity and this person that now they suddenly love's identity, they get afraid. And to deal with the anxiety and to create distance, they don't move just a little bit down the scale. They run all the way to the other end of the scale, and they say, no, you're here to kill me, aren't you? You hate me. And so now they're suddenly in the bad area, and then sometimes it'll cycle back. No, I can't think about that if they're bad, and we have this relationship, then maybe I'm bad, and I don't want to be bad, so no, they're good now. And it goes around and around and around. This idea of splitting is there. When we think in terms of treatment for people with BPD, one of the most important things to remember is to maintain control, self-control in the situation, and don't get upset by anything that the patient says or does. So the person who has this, you know that they don't have a lot of control, that this is what you're in store for, and as you go to work with them, they're going to say and do things that ordinarily from other people on the street would be highly inflammatory and aggressive and upsetting. You must maintain control and not get upset about anything they say or anything they do, realizing that this is part of what they're struggling with and you're there to help them. Next, you need to establish rules and guidelines, clear rules and guidelines. We're going to work together, and here's behavior I will not accept and things I will not accept, and here are the consequences if you breach these rules and guidelines. And so establish the rules and guidelines, spell them out clearly, and then spell out your expectations. I expect you to talk to me and to sit here quietly and to behave in this particular form or fashion, and then be firm. Once you've established the expectations, establish the rules and guidelines, be firm. Don't be harsh, but be firm. The person will probably try to test, is this really what you mean? And as long as you back it up kindly but firmly, often they'll get the point. Remember, you're still dealing with someone who, at least in their emotions, is highly chaotic, and yet they understand these sorts of things. So you maintain control, you establish rules and guidelines, you spell out the expectations, you're firm with those, and then you want to set a consistent schedule. Consistent scheduling actually helps in the process. Okay, we're going to meet every other day at 3, and so every other day at 3 you've got to be there. They kind of count on that sort of regularity assists them. And then finally, when they do make progress, when they do keep within the bounds of the expectations, the rules and the guidelines, reward them and give them positive reinforcement. Rewards and positive reinforcement go a long way towards helping them. It takes time, but they can be helped. So this has just been a cursory overview of some of the things related to borderline personality disorder. One, the possible name change to emotionally unstable personality disorder, the unpredictable nature of it, the idea of splitting, all or nothing thinking, You're either all good or you're all bad. And then some of the treatment overview here that can be very beneficial and helpful. If you'd like to learn more about this and related topics, underneath this video you'll see a link. If you'll click on that link, it'll take you to the website with that information. And while you're at that website, you should find a link to an ebook that's ready for immediate download. Today, we want to go over coping with disability and ways that people can be helped who are going through the experience of a new disability. Recently, I heard of an acquaintance who had suffered an injury while diving into a swimming pool. They'd hurt their neck and now they're paralyzed from the chest down. Of course, before this they'd been very active and lived a very full life, and now not only are they paralyzed so that they can't feel or move, but they can't do many things for themselves. And now the family is going to have to transition and make changes in order to deal with this new situation of providing the care for this person who used to provide the care for them. And there's a lot of unanswered questions at these times, and so if you're going to help people learn how to cope with disability, there's two areas that are critical. The first is helping them deal with the common emotions that people experience as they move into this new lifestyle, this new time with the disability affecting them personally or someone that they love in their circle of friends or family. So the common emotions that they have to deal with, helping them through that, helping them know what to expect and experience. And then two, getting them peer help, peer groups to surround them in order to see them transition from what life was like prior to the disability to what life will be like now after the disability. So we'll begin then with common emotions. When someone first experiences a disability, there's a grieving process that takes place. Depending on the severity of the disability and the type of disability, not only the person who is experiencing the disability, but those around them often go through a period of grieving. They're emotionally dealing with the dissonance caused by the way things used to be and now the way things are. So this friend of mine this acquaintance who had injured their neck and is now paralyzed. Before they were very active, and now they're passive, they're stuck, they can't feel, they can't move, and others are doing things for them. So not only that person, but those around them move through a common grieving process as they cope with it. In that grief process, the three main emotions that are generally felt and experienced are anger, frustration, and guilt. And these also are associated with grieving as well. Anger, why me, why us, why now, why did this happen? So there's a sense of anger, sense of frustration. I don't know what to do. I don't know what to expect. Where are we going to get help? Where are there resources? I feel helpless. And in some ways that gives way to hopelessness. So there's anger, there's frustration, and then the biggest one that I think most people need help with is guilt, feelings of guilt. Why? Why feelings of guilt? Basically, the person starts to say they're suffering, and the guilt process is mostly for those close to the one who has the disability, not the person with the disability themselves, but family, friends, and loved ones close to the person who now has a disability. They feel guilty. Why them? Maybe it should have happened to me instead of them. And then along with that, if they're suffering, they start thinking this way: I want to end their suffering. And one of the best ways to end their suffering is, I wish they just would die. I wish they would just go on, and it would have been better for them instead of having the injury and the disability if the injury had just killed them. If they just died, they wouldn't be suffering, we wouldn't be in this situation. And because they feel sorry for the one who has the disability, and perhaps they're feeling sorry for themselves, and now they're in a new difficult situation, and they want relief all the way around, wishing that the person had died instead of being left with the disability causes a great deal of guilt. I'm wishing this person were dead. And even though there may be good motives behind it, I want to end their suffering, the fact that they think this at all often induces guilt feelings. The second form of guilt that comes in is associated with perhaps this person who has the disability will now need permanent long-term care in a facility. And ordinarily this really bothers people to say, I've got to give this loved one into the hands and care of this facility for long-term care, and I should be the one providing the care, but I don't know how I can do that. I don't have the time, I don't have the resources, and they feel guilty for having to commit someone to a long-term care facility. And so it's very important to help them deal with the anger, with the frustration, and especially with the guilt that they will experience as they go through this process of dealing with the new disability. In order to help people with this, it's not only important to inform them, this is what you can expect and here's how we can help you through those emotional experiences, but to get them concrete help, and this is where number 2, peer groups come in and are so critical. Now, professionals need to set the agenda and push things forward in terms of here's the best way to help this person. The professionals need to do that, but in terms of actually walking through the process and providing the best care possible, peer groups have been found to be invaluable. So you get someone or someone's, a group, a peer group, who has already experienced this to then come alongside those who are new to it and walk them through it. And here's what a peer group can help provide. 1, education. They can say, look, I know where you are, I've been where you are, not knowing anything, utterly clueless, helpless, hopeless, frustrated, angry, all that stuff. Don't worry. Here's the information you need about this disability, how we can cope, how we can deal with it. So their first function then is just to provide basic information. 2, they provide support. I know how you feel, and I can actually say that because I've been through it. I was where you are now, and I want to help you. And they can put an arm around them and support them. So care, comfort, and support are huge along with the education. And then having a peer group around them helps prevent social isolation, because basically when people go through this, maybe they're embarrassed, maybe they're frustrated, they don't know what to do, and they tend to pull in and isolate, and this is very harmful in the long term to the one who has a disability and to those around them, to be isolated and cut off from outside help and support. So having a peer group established helps prevent the social isolation. And then they can help provide information on resources. They can say, look, this is what we're using. Here's the organization we're going with. Here's the help or the program or whatever that has seen us and done us the most good. So here's the information for you so you can do that. There's a great deal of relief. I have some friends who have a baby with Down syndrome. It's a difficulty, but when they got plugged into a network, plugged into a peer group, all of this started to flow. They got the support from other parents who have Down syndrome babies. They got educated about it. They're not isolated. They spend time with these people. They've been told about resources to help with rehabilitation and various forms of therapy and things like this to help train and teach and assist not only the parents but the baby. And then they get coping strategies. Look, at different milestones, you're going to experience this or feel this or maybe go through that. Here's how to cope with that. Here's how to help. And then finally, they can help say, look, your role is now being redefined. You used to think your role was this, but now it's this. And I understand what that feels like, from being the one cared for to the one providing the care. And the difficulty with it. Well, let me help you through that difficulty of transition to your new role in helping the person with the disability. So essentially 2 things then in helping people come to terms with a new disability and cope with it. 1, common emotions, educate them about this, that they're going through a grieving process, and 2, get them plugged into a peer group that can meet and supply all of these much needed things. So this has been just a basic overview then of the 2 primary things that are helpful in people dealing and coping with disabilities. If you'd like to learn more about this or related matters, underneath this video you'll see a link. If you'll click on that link, it'll take you to the website that has that information, and while you're at that website you'll also find a link to an ebook that's ready for immediate download. Today in this video we want to go over a category of drugs that are abused or substances that are abused called inhalants. When we think about inhalants, what we're talking about is a chemical substance in a vaporous form that is brought into the body, ingested in the body through the lungs or breathed in. It's inhaled, thus the name inhalants. These chemical substances rapidly make their way into the blood system through the lungs. It's almost immediate, rushing to the brain, producing a reliable, fast, and brief intoxication. So it always happens, it's reliable, it's a very quick high because it's immediately introduced to the blood through the lungs, and it's brief. You don't have a long period of downtime afterwards. So if you're looking for a quick buzz, inhalants tend to be the way to go. Because of those things that are inhaled, these substances are legal, readily available. They can be purchased at almost any store. What you find then is that adolescents and pre-adolescents often abuse this type of substance. They can find it around their houses or they can easily obtain it. It's easily transportable, hidden, things like this. And so therefore it is open to a great deal of abuse. And they are dangerous. They can cause both physical and psychological dependence as well as brain damage when abused. I knew from my own experience in junior high, way back in the day, of a particular boy who was much older than the rest of us, and when you spoke to him, you realized something wasn't quite right about him. Why was he so much older than us and yet in junior high? Why did he have such a hard time communicating? Was it a learning disability? No, he had brain damage from abuse of inhalants. And for me, that became a living testimony to the danger of this particular substance abuse because of what it can lead to. The things that can be used and found around the house or purchased legally at most stores that tend to be used as inhalants are things like paint solvents, glues, cleaners, gasoline, liquid paper, nail polish remover, cosmetics, and other aerosol sprays. It is unfortunate that these things have a normal use, but yet through adolescence and pre-adolescence are finding another use as they seek to stimulate themselves physically through this method. It's reliable, fast, and brief. The most common side effect is headache afterwards. Of course, because it's a substance, a chemical substance that doesn't belong in our bodies, it can cause irreparable harm and damage to the brain. So it's something to be aware of and concerned about, even though it can be easily hidden because you don't see the effects of someone who's drunk for many hours while the liver metabolizes it, or other effects that are noticeable because it is such a rapid high and then brief intoxication. These sorts of things need to be known and be aware of, especially if you're a parent who has children or if you're someone who works with adolescents or pre-adolescents, to be aware that this is something that should be a concern and to be watched for. All right, well, that's just a brief overview of inhalants, what they are, what they do, the effect they have, and some of the dangers involved with them. If you'd like to learn more about this or related matters, underneath this video you'll see a link. If you'll click on that link, it'll take you to the website that has that information, and while you're on that website, you'll also find a link to an ebook that's ready for immediate download. In today's video, we're going to go briefly and touch lightly upon Dr. Freud's theory of personality as it relates to the id and the ego and the way they interact. If we want to look at this model, we're talking about a psychological model of the structure of the mind. This does not correspond to places in the brain or to anything about us physiologically. You can't point to a part of the body or the brain and say that's where the id is, and that's where the ego is, and that's where the superego is. This has to do with our mind and Freud's theory about how people live and interact with the world. And he saw three different forces at work within people. He said that we are all born with this basic identity of pleasure seeking, or the id. The id is entirely consumed with self-gratification. If I'm hungry, I want food now. If I am uncomfortable, I want to be made comfortable now. It just wants to meet its needs. It is heedless and regardless of reality going on around it, of other people's needs, of other people's wants, whether it hurts someone else. And Freud would say this is seen most clearly in babies. If they're hungry, they cry. They get fed, they stop crying. If they have a dirty diaper, they cry. If they get changed and are made physically comfortable, they stop crying. If they're sleepy, they cry, and you put them to sleep, they stop crying. So it's whatever they need immediately, that's the id. This is the innate, born into us, selfish nature that says, I want what I want, and I want it now. It's the aggressive part of us, the pleasure-seeking part of us. It's all of our basic drives, hunger, sex, aggression, whatever. All those basic drives come out and are part of the id, and this is from birth. Then Freud said, around about the age 3, the ego starts to develop, and it's the ego's job to satisfy as much as possible the desires of the id while taking into account the reality around it. So by 3, the child is starting to realize that there are other people who also have wants, desires, and needs. It is also starting to realize that if it immediately tries to gratify itself, sometimes that leads to pain. And in order to maximize pain, the ego develops to satisfy the needs of the id while taking into account reality, other people's, other needs, other wants, and the best way, given the current state of affairs, the current reality, to prolong pleasure and to minimize pain. So the ego develops to moderate the id, but also to more adequately and over the long haul satisfy the id. So the ego's job, once again, is to meet the needs of the id. The id says, I want, I want, I want. The ego comes along and says, okay, you want, but here's the reality of the situation. In order for you to get what you want, we're going to have to withhold here, restrain here, pursue this, that, there. And that will lead to long-term pleasure, although it will sometimes hamper short-term gain. And we're going to want to avoid the short-term pleasure seeking, as it may lead to more long-term pain later. And then around about the age 5, Freud said the superego starts to develop. This is the part that we would ordinarily call the conscience. It doesn't deal with the real, but more the ideal, what ought to be, the way things should be. And basically there's this conflict then between the superego, which says this is the way things ought to be based on the morality of society, and the id, which says I want this now, and the ego stands between seeking to rationalize, harmonize, and satisfy both poles. Society says this is the way things ought to be. I want this. Here's the way things are right now in reality. How can I keep the superego quiet, keep my conscience placated, and get what I want without long-term hurt based on the reality of the situation now? So the ego is the one who interacts between these opposing forces, but its primary job is to meet the needs of the id, those primal drives of hunger, aggression, intimacy, things like this, to meet those needs, but in a way that deals with reality. So remember, the id is the basic drives. It's based on pleasure, and it wants it now. Pleasure and aggression, basic drives, born with it. The ego is based on the reality principle. This is the way things are really happening right now. This is the current circumstance. How am I going to meet the current circumstance, satisfy the needs of the id, but not produce prolonged pain? So satisfies the id based on reality. The superego is the conscience and deals not with the real, but with the ideal, the way things ought to be as it is informed by the current culture and society. Born with the id, age 3, the ego starts to develop. Age 5, the superego starts to develop, unless there are hindrances to that development. This is Freud's theory, then, of the interaction of the id and the ego. If you'd like to learn more about this or related matters, underneath this video you'll see a link. If you'll click on that link, it'll take you to the website that has that information. While you're at that website, you'll also find a link to an ebook that's ready for immediate download. Today I want to talk a little bit about Obsessive-Compulsive Disorder, OCD. Of course, one of the jokes related to this, if you're really OCD, it should read CDO. It's got to be in alphabetical order. But all joking aside, it is a serious disorder that can hamper people's life, and it is characterized by the recurrence of unwanted or distressing thoughts, the need to repeat behaviors or rituals, and it can get to the point where it gets in the way of someone's normal living, from their ability to perform their job or other ordinary functions, and that they begin to realize that these thoughts or these behaviors are not ordinary or normal. They're not reasonable, and they get in the way of daily activity. Usually these characteristics, their typical onset is in childhood or adolescence, as it shows up in, once again, the recurrence of the distressing thoughts or the repetitious behaviors. And usually when we think about this recurrence of unwanted distressing thoughts, one of the things that comes to mind that's fairly common to most people, but in someone with OCD would be all-consuming, would be the idea of, did I leave the iron on? Did I forget to turn off the stove? Are the lights still on? Did I lock the doors? Okay, these are ordinary things that we sometimes forget and think about, and then we go check and we're okay, or we can move on. Someone with OCD, though, has the recurrence of this unwanted questioning over and over and over and over and over again, to the point that they actually can't do anything else but think and worry about, did I lock the door? Did I lock the door? Did I lock the door? Is the iron off? Is the iron off? Is the iron off? And they've actually got to repeatedly check, and even after they've checked, the thought is still there and they have to go back and recheck. The thought is still there and they go back and recheck. And it's this distressing situation that causes the most problems. Now, it's not just those ordinary thoughts that we think of that come back repetitiously. Sometimes they include thoughts that are distressing or disturbing because of the nature of the thoughts that repetitiously come up. I might hurt someone, or have I hurt someone physically in some way or another, and it comes up repeatedly. I might hurt someone, or I have hurt someone, or I want to hurt someone. Anyway, it's the repetition of these unwanted, distressing thoughts that are part of the obsessive nature of the disorder. The compulsion comes in under the behavior, the need to repeat Behaviors or rituals. This would be the endlessly arranging things in a particular order, obsessing over and consistently feeling a compulsion to put things precisely where they belong. Ritualistic behaviors that have to be repeated before anything can be done further. The constant washing of hands, the constant counting of things. Things that are, once again, seen to be not necessarily reasonable, and they inhibit or interfere with daily activities. So the obsessive thoughts, the compulsive behavior get in the way, and usually treatment for this involves cognitive behavioral therapy and antidepressants to try to get the person to deal with whatever it is that they're stuck on mentally that's compelling or moving them forward into these obsessive thoughts or this compulsive behavior. There is help for those who have this, thankfully. And if you'd like to learn more about OCD and the things we've talked about here just briefly, you will find a link underneath this video. Click on it. It'll take you to a website with more information. And on that website, you'll also find a link to an ebook that's ready for immediate download. Those that are tasked with helping people make productive changes to their life, dealing with the pain and the stress and the hurt of dysfunctional life, have various approaches to, one, identifying problems, and two, finding a solution to those problems. One of the ways to both identify and help solve problems is the psychoanalytic approach. The psychoanalytic approach is also called the psychodynamic intervention approach, and it basically follows the following tenets. Just briefly, I want to just talk about the few feeder views that feed into this view so that you have maybe a broader idea where it comes from. So the psychoanalytic or psychodynamic intervention approach draws upon psychoanalytic theory, ego psychology theory, psychosocial theory, and object relations theory. So all of those things are drawn together and coalesce in this psychoanalytic approach. The key tenets that we want to talk about is, number one, the social environment in which the person exists is considered the primary external influence. Nothing is greater as an influence externally to the person than their social environment. So you must know the environment in which they're in and get all the information you can there to realize what external factors are feeding into the equation and causing the dysfunction and the problems. Second, behavior, how people act, flows from the unconscious mind and unconscious drive. So in many ways, they don't know why they're doing what they're doing. It's flowing out of the unconscious mind, drives, motives, and those sorts of things. But their behavior flows out of that. So you've got the external factors of the social environment, and then internally, these unknown motives and drives from the unconscious mind. Next, dysfunction comes about by the stress produced through conflicts in the unconscious mind. So stress-producing experience and conflicts in the unconscious mind express themselves in dysfunctional behavior. So you've got the external influences of the social environment, you've got motives and drives coming from the unconscious mind producing behavior. Dysfunctional behavior shows that there is stressful conditions, that there is conflict causing experiences in the unconscious mind then being acted out in dysfunctional behavior. Finally, if you're going to get resolution to this, what you have to do is draw out the unconscious mind into the conscious mind. What's going on with them in places they don't know subconsciously, drawing that out into the open, into the conscious mind. By doing that, you actually produce stress. The reason it's in the unconscious mind is because they don't want to deal with it. And in some ways, the stress and the conflict has pushed it there. You draw it out, and you use the energy created from the stress and the conflict as it comes into the conscious mind to help produce changes. So you would talk them through it and say, look, I know this is painful, I know this is hard, let's do something about it. Let's actually use that energy productively to bring about a good change in your behavior, changes in your thoughts, changes in your behavior, changes in your environment so that things start moving in a good direction. So the key factors to remember here again in the psychoanalytic approach is that the primary external influence is always the social environment. All of our behavior flows from motives and drives found in our unconscious mind. Dysfunctional behavior is produced by stress-producing experiences and conflict in the unconscious mind, and the way to help alleviate that or change that or bring about good is to take the things that are in the unconscious mind, bring them forth into the conscious mind. It's stress producing to do that, but then you help them use that energy from that stress to redirect them and promote positive changes in their life and their behavior. If you'd like to learn more about this, you can click on the link underneath this video. That link will take you to a website with that information, and also on that website you'll find there a link to an ebook that's ready for immediate download. I want to take just a few minutes to talk a little bit about psychotropic medications. And within this category, we are talking about medications that help deal with mental disorders. And you need to have a good working knowledge then of what these medications are, their benefits, their side effects, and their risks. With each medication based on what it's designed to do, and there are 3 categories that we're going to look at. Various medications have benefits for that category, but there are also side effects to be considered and even risks, certainly when we get to category 3 with the stronger psychotropic drugs. So once again, when you do talk about psychotropic medications, you need to realize that there are 3 different categories of these medications, and you need to have a good working knowledge of each one's benefits, side effects, and risks. So let's talk a little bit then about these medications. Category 1 medications are used to treat things like minor depression, anxieties, and they include all the anti-anxiety agents, sedatives, and hypnotics or sleeping pills. Category 1 medications affect the limbic system, and they produce a feeling of calm and sedation. So minor depression and issues related to sleeping or anxiety, and they want to produce calm, sedation, sleep, things like this. So that's the category 1, fairly minor, and yet there are benefits, side effects, and risks with each one. Category 2 treat major depressive disorders, and they include all the standard antidepressants. Under these categories in category 2, they include all the tricyclic and tetracyclic medications, the monoamine oxidase inhibitors, and stimulants. When we talk about treating severe depression, sometimes stimulants can be very useful in that regard. So category 2, major depression, the tricyclic, tetracyclic, monoamine oxidase inhibitors, things like this. Now when we get to category 3, this is where the real heavy-duty neurological and psychological issues are located. Category 3 treats major mental illness, things like schizophrenia and other psychoses. So in these medications, we're talking antipsychotics, anti-manic medications. If a patient is saying that they're having difficulties with hallucinations, delusions, peculiar behaviors, these sorts of things are treated by this category, category 3 drugs. They're the antipsychotics, the neuroleptics, the lithium carbonates, and there are 5 families of antipsychotics. The phenothiazines, the thioxanthines, the butyrophenones, the indolines, and the dibenzazepines are the main families within category 3 psychotropic medications. You need to be thoroughly versed in all these categories, knowing who's in what category based on what they're complaining of. Category 1 being the lightest, those having minor depression, sleep disorders, anxiety issues. Category 2, major depression, and category 3, true major mental illness here, the hallucinations, delusions, and very odd behavior. Be well versed in not only what system they affect, limbic system, things like this, but also the benefits, side effects, and risks. If you'd like to learn more about this, click on the link beneath this video. It'll take you to a website where there's more information, and there's a link on that website for an ebook for immediate download. Let's think together for a minute about chronic insomnia. I'm not speaking today about occasional insomnia, which everyone suffers from, but chronic, persistent insomnia, and some of the reasons and forms that insomnia takes. And we have some of those on the board behind us, and so for the next few minutes we're just going to talk about those together. The first form of chronic insomnia I want to go over is psychological insomnia. Psychological chronic insomnia is due to anxiety or fear about the inability to fall asleep, and the fear itself of not being able to fall asleep keeps the patient from falling asleep. And this is so persistent and chronic that it does create problems. It is an issue that needs to be dealt with on a psychological level, but it can cause a great deal of stress to the person who increases in their phobia the more times they are unable to fall asleep, which only exacerbates the situation. Another reason for chronic insomnia is sleep state misperception. In this particular example, someone is in sleep study been recorded to have normal sleep patterns through all 5 states of sleep and a normal duration of time, and yet when asked about their sleep will report that they got no sleep or very little sleep, or that the sleep they did receive was of a poor nature. And even when they're shown the results that you slept a normal amount of time, entered all 5 levels of sleep, will still persist in the belief that they got little or no sleep and that the lab results must be lying to them. Also a difficult psychological situation to deal with, as the person has a hard time believing the lab results over their own experience. And it's not entirely understood why this happens, but it is an issue of chronic insomnia where the person is getting plenty of sleep and yet they believe and feel as if they get little to none. Moving on then, other forms of chronic insomnia would be hypnotic dependent sleep disorder. In this case, someone trying to deal with their insomnia has started taking hypnotic drugs. In this case, we would commonly call them sleeping pills, in order to sleep, and has become dependent on them and found that they need to take higher and higher dosages and quantities in order to get the normal amount of sleep. And when they realize they become dependent on them and they're not working as well as they had in the past, oftentimes their doctor will take them off of them. And what they find when they are completely removed from the person, they are no longer taking the sleeping agents, that the chronic insomnia kicks into high gear and they report a great difficulty in falling asleep, a great deal of irritability and other issues and problems, not only from the lack of sleep, but the inability to sleep because they've come off of the sleeping pills or hypnotic drugs. Another, and the final one we'll talk about under chronic insomnia, is fatal familial insomnia, and this is a genetic disorder. And in this particular form of chronic insomnia, you have a situation where the person is genetically, because of a protein that is tweaked, completely unable. It's a neurological disorder. They are unable to sleep. And of course, this is very damaging to our health, and it is fatal. The average length of time a person from the onset of this particular disorder lives is between 7 and 36 months, 18 months being the average. They go through various stages, the final ones concluding in a type of dementia, an inability to speak. There are lots of disorders associated with this, but there is no known cure for this fatal familial insomnia. It is a neurological disorder that is incurable and always fatal. Well, these are some of just a few of the chronic causes of insomnia that we've talked about today, and I hope you understand them a little better. Stress. It's something that every human being goes through at one point in their life or another, often multiple times, and sometimes over a prolonged period. The universal human response to stress has been dubbed the General Adaptation Syndrome, or GAS for short. It has 3 stages. The General Adaptation Syndrome, or the GAS response to stress, has 3 stages, and we're going to go over those now. The first stage is called stimulation. At this stage, the stress has been introduced to the person, and their body responds by the hypothalamus stimulating the adrenal medulla to release epinephrine or adrenaline. Epinephrine and adrenaline are the same thing depending on what part of the world you're in. They're going to favor one or the other. Epinephrine is the Greek-derived word for this hormone, and adrenaline is the Latin-derived word for this hormone, but they're the same thing. So the hypothalamus stimulates the adrenal medulla and releases epinephrine. The glucose level rises, the heart and respiration rates increase, and the individual becomes alarmed. We've all experienced this. Stress comes in, things heat up, adrenaline or epinephrine is released, heart rate goes up, respiration goes up, and the person is in a state of readiness, alarm, fight or flight in some ways. So the gas response then is managed by the adrenal and the pituitary glands. So the first level then is stimulation. If the stress is not resolved at this level, then the second stage that the General Adaptation Syndrome goes to is resistance. At this stage, the body resists the stress by returning respiration and heart rates to baseline. The hypothalamus commands the pituitary gland to release ACTH, a hormone that causes the adrenal cortex to release cortisol. Cortisol is a chemical that maintains high levels of blood glucose. So this is once again the body's attempt to deal with whatever is bringing about the stress. So stimulation puts a person in an alarmed or heightened state. It persists, resistance comes in, the body trying to bring things into line, into a normal state. Once again, the hypothalamus is critical to all this. In the initial stage, it stimulates the adrenal medulla to release epinephrine. In the next state, it commands the pituitary gland to release the hormone ACTH, which causes the adrenal cortex to release cortisol to keep the blood glucose levels high. Finally, if the stress is not resolved, the third stage for the general adaptation or gas syndrome is exhaustion. Here, the pituitary and adrenal glands are utterly fatigued. The physiological processes start to break down. And it is this stage right here, this exhaustion stage, that if it is prolonged is most damaging to health. So stress management is extremely important. Stress comes into everyone's life. The universal response of every human being experiencing various levels of stress has been generalized as the gas adaptation or the general adaptation syndrome. It has three stages: stimulation, resistance, and then exhaustion, this stage being the most damaging to health. The hypothalamus involved in this. First stage, releasing epinephrine. Second stage, releasing ACTH in order to get cortisol to come out and raise the blood glucose levels. And then finally, when the pituitary and adrenal glands are utterly fatigued, everything begins to break down and the health begins to deteriorate. If you'd like to read more and learn more about stress and find out exploration more in this area, then please click on the link beneath this video. It'll take you to a website where you can study further, and you'll also find an ebook there ready for immediate download.